Albin?
Yeah.
हाँ. Dr. Vinod, are you there? Yeah.
Yeah, I'm here.
Okay, fine. Thank you. So, we'll start then, huh? Good evening, everyone. Good evening, my seniors, SAMS office bearers, Dr. Avinash Bhosle, Dr. Balaji will join soon. Then our faculties today, Dr. Albin Augustine and Dr. Vinod Gadiyar. I welcome you all for this webinar, which is organized by ISA Navi Mumbai. And thanks for accepting the invitation to be a faculty. And actually, 11th of December is our ISA Navi Mumbai's Foundation Day. And to mark this event, we have organized a webinar in association with SAMS, that is Society of Anesthesia Maharashtra State chapter. And our theme today is maintain and retain your brain. So we have two experts, Dr. Albin Augustine, he is a consultant at Stoke-on-Trent, and Dr. Vinod Gadiyar, he is also a consultant, and apart from the consultant anesthetist, and he is a chronic pain consultant from Fairfield Hospital, Bury, Manchester. So they'll share us with their knowledge, and we can gain a lot of information from them. So without delaying further, we'll start our webinar. The first speaker is Dr. Albin Augustine, and afterwards, Dr. Vinod will share his knowledge. Just some rules I want to tell you. We have only speaker which will be unmute. Rest all will be muted and will be in mute mode. Whatever questions you have, please type them in a chat box. And at the end of both the sessions, we'll start Q&A session. And after all the questions are finished, if you want to interact with faculties, you can interact. But while doing that, keep your mobile on silent mode. Okay, so we'll go ahead with our first talk, which is anesthesia for stroke. Oh, sorry, I'll have to share my screen. 1 minute, huh? Can you all see me? Can you all see my screen? Hello?
Yeah, I can see.
Yeah.
Yes,
We can.
madam.
Yeah. Our first speaker is Dr. Albin Augustine. He's done FRCA and he's a consultant neuroanesthetist at University Hospitals of North Midlands in the UK. He did training in anesthesia from India from CMC Vellore. And he does neurosurgery list in a week, neurosurgery, interventional neuroradiology, and robotic urology. And he has special interest in TIVA and simulation training. Over to you, Albin, now. Thank you.
Thank you. Okay, if you come off your screen, I can share my screen now. Can you see my screen now, Vaishali?
Yes, we can see Albin.
And you can hear me clearly, yeah?
Yeah, absolutely. Yeah.
Okay, thank you so much. Thank you, Dr. Vaishali, for the invitation, and thank you for all the distinguished anesthetists for sparing your valuable time on this Saturday evening for you. Okay, I'm not going to tell you about how to give anesthesia because you're already experts, but I will share with you the knowledge and experience we have in developing this new service and how we have gone about and how our hospital has implemented this and our results. So the topic is anesthesia for mechanical stroke thrombectomy. So this is where we are based. This is where we are based. This is West Midlands, as you all know. UK has so many counties. And if we expand that map, we are in this place called Stoke-on-Trent. And it is a University Hospital of North Midlands, it is called. That is where we all work at the moment. Fine. So this is the main entrance building. So this hospital caters for about 250,000 people. It has all specialties, including neuro, cardiac, pediatrics. It's a major trauma center and also a stroke thrombectomy center. What we do not do is children with major pediatrics, and we do not do transplant operations. So this is the aerial view of the hospital. It all looks very nice from the top, but you should believe me that it's totally mad and very busy inside the hospital. Okay, regarding stroke thrombectomy, this is about interventional radiology. I'm sure many of you work in interventional radiology, and I'm going to talk about what we do there, and especially for today's talk, what cases we do in IR, the stroke pathway and various definitions, evidence for thrombectomy, the concept of penumbra and the core, how artificial intelligence is helping us, evidence for GA and optimal blood pressure for thrombectomy, how to measure quality and outcomes, what are the good metrics, what is a good unit, and the future of thrombectomy services for the United Kingdom. Right, so this is the intervention radiology suite. We have two intervention radiology suite. One is IR1, where they do all the abdominal aortic aneurysms and vascular cases. And this is the other IR2, where we do neuro and also vascular cases. Right, okay. Okay. So the procedures, what we do in interventional neuroradiology as a neuroanesthetist group of 7 or 8 people covering this, normal cerebral angiogram, which you all know, coiling of aneurysms, we do around 100 in a year for subarachnoid hemorrhages, thrombectomy between 80 to 100, which it was like that. I will show you how it has changed over the years. We do embolizations for AV malformations, dural AV fistulas, various cerebral tumors, and for operations later, spinal cord angiogram and location of AV malformations, and some chronic brain procedures for cancer, and then degenerative disease, kyphoplasty and sacroplasty. Occasionally, we do blood patch for chronic headaches, and some maxillofacial patients will come for epistaxis as their tumor area starts sloughing. Okay, so these are the cases. So anesthetists now are involved in stroke in various ways. So it can be for acute ischemic stroke. It can be for subarachnoid hemorrhage. It can be for intracranial hemorrhage. It can be for subdural hematoma. It can be for extradural hematoma, and for the MCA infarct, where we do a decompressive craniotomy. So in all these facets of neurosurgery problems, anesthetists or neuroanesthetists can be involved. I'm sure many of you are also involved in these cases in an everyday practice. Let's go to the next slide. Okay, I'll start with the case report. As you can see, this is the internal carotid artery winding up and going into the intracranial region. It is full of dye, and this is what is the intracranial blood vasculature, which is not seen. So she was a 67-year-old female. Around 9:40 a.m., she was shopping in a supermarket called Aldi. She fell down. The 999 was dialed. Ambulance came in. She came around 10:30 a.m. to the accident emergency or the casualty suite. A clinical examination and CT was done. And then she was diagnosed of left dense hemiplegia with aphasia, a previous medical history of diabetes plus hypertension and increased BMI. She had an middle cerebral artery thrombus, and she was scheduled for alteplase, and stroke thrombectomy was done. She was scheduled for that. Okay, so as she came into the interventional radiology suite, the intervention went through the femoral root, went into the carotid and into the MCA, and you can see the clot, a very dense clot being removed from her. After that, if you see this is the clot, and after removal, you can see the full perfusion of the brain, which has completely perfused well, and you can see the MCA, ACA circulation well established. What I want to tell you is, after the circulation established, she started speaking and moving her left arm and left leg immediately on the operation table. So this is the dramatic effect she has. If you would have left her only with alteplase or with no treatment, she would have been paralyzed for life. So this treatment is life-changing, a very dramatic treatment, which I will talk about more in the future slides. So this is our intervention radiology suite. As you can see, it's fully occupied by the radiologist and the radiographers. There's so many equipment inside, and we, the anesthetists, you can see the monitoring monitor there, anesthesia machine there, and so much of radiation going on, so we stay outside. So anesthesia outside the operating suite, operating theaters, as you all know, is very challenging and is very risky as well. So these are some of the clots from large vessel occlusion. When I talk about large vessel occlusion, I mean anterior cerebral artery, internal carotid artery, and the MCA, middle cerebral artery and its branches. These are some of the big clots which come out from the middle cerebral artery, which causes our stroke or dense hemiplegia. For all practical purposes, I'm only going to talk about acute ischemic stroke. So stroke, as you all know, it could have happened in our own relatives, in our own family, and we can see even as doctors, many people come with stroke. It is one of the fourth leading cause of death in the whole of the world. It's one of the highest disability. So the disability and the rehab work and the family trauma and the health economics for the whole country and for the family is huge. So there is evidence now to show that there's enough treatment for this, and we have to work towards this to remove this highest disability from stroke. So this is the NHS England, that is the National Health Service, just like we have got in India, the Government Health Service, the National Health Service, where you can see the budget is at least going to around 158 billion, okay? So that is the amount of money being spent on the National Health Service, and out of this, at least 26 billion is spent on stroke, on neuro and neurological and neuro rehab services. The budget for neurological disorders and neuro rehab is very, very high. One of the highest disabilities, as I've just spoken to you. So the treatment available for stroke is either a drug, a clot buster, and now you can also go into the artery and remove the clot. So you've got intravenous thrombolysis and intravenous thrombolysis plus thrombectomy versus thrombectomy alone. So this is the treatment that is available. Now, this is, as you all know, the alteplase, which was by NINDS trial and ECAS trial in 1997. By the time it came to various countries, there was more than a 10-year delay. So this odds ratio line, you can see this line is for the no benefit. That is, if you don't do anything, that is odds ratio 1. And above this is if you do something. So this is the odds ratio on the y-axis. This is 60 minutes time on the x-axis. If you see, there is a clear benefit, and this benefit extends till 150 minutes or nearly 180 minutes. If you extend this, that is the lower limit. So up to about 3 hours, you can give the alteplase or the clot busting drugs, you will get benefit. This is where you get the maximum benefit, where the confidence interval is so narrow, and then some of the patients will not benefit because on the either side of the confidence interval. So there is definite benefit if you come in this first 120 minutes, a huge benefit. Some patients will definitely benefit even if you come later. Fine. And so this is where it plateaus off. After this 150 minutes, there is almost no benefit at all. In fact, you can cause more harm because of alteplase or the clot busting drug. So in 2008, the New England Journal of Medicine published this new trial with thrombolysis alteplase. You can extend it up to 4.5 hours, right? Okay. So this is constantly changing. The time is going, but up now the best benefit you will get for 3 to 4.5 hours. Also, if you come after an acute ischemic stroke, it is beneficial. And so if you look at the American guidelines, ischemic stroke guidelines from the AHA, you can see alteplase is level 1 evidence. Okay, it's level 1 evidence, and everybody should get it between over 60 minutes. It should be able to receive it in a hospital as long as we recognize the symptom of stroke and arrive early into the hospital, and the hospital staff and the doctors recognize it and give the drug early. So as you can see, this is the number needed to treat. Number needed to treat is the inverse of absolute risk reduction, where if you come within 90 minutes, the number needed to treat is 5, 180 minutes, it's 9, and 360 minutes, 1. So the earlier you come, the benefit is greater. The lower the NNT, the treatment effect is even greater. You can make so much savings for that. Now, because we did not see this alteplase before in our practice, now patients are coming with thrombectomy, alteplase infusion going in to the neuroanesthetist or to the anesthetist. We must be aware one dangerous side effect of the alteplase, which is angioedema associated with thrombolysis. So especially if they are on ACE inhibitors, there can be swelling of tongue or swelling of the floor of mouth and pharynx progression within 30 minutes and may require intubation or an airway arrest. So anesthetist should be aware of this. This is treated with histamine. I'm sure all of you know how to treat anaphylaxis and allergy. You're experts at it. You can give diphenhydramine, ephedrine, nebulized. You can give nebulized epinephrine. And ultimately, there are alternative therapies which are C1 esterase inhibitors, which the hematology department will have. So it is just for us to be aware of angioedema, tongue swelling can occur because of this. Now, the problem is thrombolysis is not enough, okay? Now, all patients who come, even if they get thrombolysis, it is not going to cause full recanalization of the large vessels which have been occluded. This is a big problem. So if you see only 20% at acute recanalization, if you see the M1 branch of the middle cerebral artery only 32%, M2 branch only 30%, basilar artery only 30%. And if in severe strokes, very severe strokes, thrombolysis is definitely not enough. So we need something more to remove the clot. So now here you can see this new technique where the radiologist goes there, there is a clot there. He goes in, pulls the clot, and there's full perfusion back again. So this is a big revolution in stroke care and produces dramatic results. So this is the intervention radiology suite again, where you get all the patient parameters are there. This is the radiographer there. That is the scrub nurse there. That is the intervention radiologist going into the groin puncture and then going into the cerebral circulation to remove the clot. And this is how it will appear, and we are very far away. We should be with lead aprons and thyroid protection aprons, and we can spend at least 1 hour to 2 hours in this suite for the whole procedure. And these are the devices that are being used, which are called the stent retrievers, or some are balloon retractor device where you go in and pull the clot out. Right, okay. So I'm going to tell how a patient from home goes to ambulance and then to hospital, then comes to a major hospital, has scans, and then ultimately goes to a stroke ward and then discharged. This is called the whole flow or the workflow pattern or the journey that a patient takes for when they have a stroke. So initially, patients should recognize stroke, or the community recognize stroke, or the relative should be able to recognize stroke both at home and at workplace. And this is what UK follows. There are various parameters, just like GCS or Glasgow Coma Scale. We have got the face, that is the face, the arms, and all these things that can go wrong. And this is the face is a way of recognizing how are you going to recognize stroke initially. So face, arms, speech, and time. So this is FAST. So FAST is the acronym that is used for the test, just like Mallampati test, just like obstructive sleep apnea test. This is the initial screening test for stroke. As soon as a patient is FAST positive, the 999 is being called, and the ambulance will recognize these signs, and they will rush the patient to hospital in blue lights. Various countries will use different parameters. For example, some countries use RACE, some countries use FAST. And every test, just like Mallampati, just like Stop Bank score, has their own sensitivity and specificity. Because of this low sensitivity and specificity, there will be very lot of stroke mimics. Many strokes can be missed. This can happen, and there can be a more overload in the accident emergency, and workflow can increase. So it is very important to recognize stroke and to make a differential diagnosis, make an accurate diagnosis so that they can reach early. So there are different ways. One is RACE, one is FAST-TD, and GFAST. So different countries, I think Spain uses GFAST, UK uses FAST. So different countries will use different methods. I think in India, they are using FAST. So coming to our stroke syndromes, that is the region of the anterior cerebral artery. This is the major middle cerebral artery territory. And then you've got the posterior cerebral circulation after this. Okay, so I'm sure, and we all have recognized, this is the internal capsule, that is the corona radiata, internal capsule. The artery surrounding us will cause dense hemiplegia. So these are the various syndromes. All of you know this. I'm not going to go into detail what symptoms we are going to get with this. This is the job of the neurologist or the stroke physician to find and make a diagnosis and start the treatment. And this is posterior circulating. This is very important because there will be sudden loss of consciousness, nystagmus, there will be vomiting, loss of airway, bulbar weakness, aspiration, there can be locked-in syndrome. It is very important for us to recognize this early as an airway catastrophe, and the mortality is very, very high. Nearly 90% mortality you will get all in posterior circulation of basilar artery stroke. Now, just like Glasgow Coma Scale, patients are given an NIHS score, that is the National Institutes of Health score. They go for LOC, gaze, visual field, facial paralysis. So they have a score. I'm not going to go into details of this. This is the job of the neurologist or the stroke doctor who sees the patient initially and presents. So the NIHS score, just like GCS, is divided into 0 to 4 minus stroke, 5 to 15, 16 to 20, and maximum score of 21 to 42. And the amount of, you can see here, this arrow here, that is the middle cerebral artery territory. There's a big thrombus there. This is the CT angiogram. You can see on this patient's right or my left, where there is the middle cerebral artery fully perfusing. And here you can see the yellow arrow, there is a big thrombus here. So it's very easy to diagnose. And we know this causes, this is stroke. If there is no blood, if there is a lot of blood, patient will go to neurosurgery. If there is no blood, patient will come to the stroke physician. So again, there you can see this classic sign, and here again, you can see there is no continuity of vasculature. So there is a thrombus. It can be an arterial thrombus, or it can be atrial fibrillation thrombus. Any of these can cause a big stroke. So what we have learned now is about NIHS. That is one of the first term I would like to introduce to you. Now, the second term I would like to introduce to you is the Alberta Aspect Score, or the Alberta Stroke Program. I'll just call it aspects. Now, what they do when they do scanning during both in the ganglionic level and the supraganglionic level, the whole middle cerebral artery, they divide into various territories, M1, M2, M3, M4, and the internal capsules, lentiform, and the caudate nucleus. All these are given 1, 1, 1, 1, 1, 1 point. All these points. Depending upon the infarction, they're given a score of 10. If it is 10 out of 10, the brain is normal. So as each place is infarcted, they reduce 1 point, and you're given a total score of an aspect score. So this is used to predict mortality. So the second term I would like to introduce the aspect score. The third term, which you can see, this is the cutoff, and then after treatment, there is full perfusion. So depending upon the type of perfusion, we can also grade, just like you got the TIMI score in cardiac, in myocardial infarction. This is called a TICI score, that is the thrombolysis in cerebral infarction grade, where there is no perfusion. 1, there is clot reduction. And if you see 2B and 3, partial filling, 50 to 99% of the territory. Number 3 is complete reperfusion. I like all of you to concentrate on this 2B and 3, because this is where we would like to achieve perfusion, right? So once again, with this reference, grade 2B is complete filling of all the expected vascular territory. Grade 3 is complete perfusion. So we would like to achieve, the radiologists would like to achieve grade 2B or grade 3 type of TICI score. So we have seen what is NIHS score. And now, how do we measure the outcome? Once we do the treatment, how do we know the patient is survived? What we all measure on is post-operative nausea, vomiting, pain score, sedation score, like that. They have what is called a modified ranking scale. So after the treatment, they looked for no symptoms, completely symptoms are gone. There is no significant disability, slight disability, or if you go to number 6, patient has died or severe disability. So again, 0 to 6. So this is another term, modified ranking score. So in modified ranking score, here you can see there is in score 1 and 2, there is no, patient is fine, can go back to work, and the family is very happy. Even mild, everybody is good, everybody is happy. Moderate, they can dress themselves, they can eat, they can button their shirt, they can get up from their bed. Whereas moderately severe and severe is bad. Especially moderately severe, they are fully dependent, they are in the bed, the family, the son or the daughter or the son-in-law or the daughter-in-law, everybody has to take care, or carers have to be employed. And then you've got severe stroke, and then you've got death. So It is divided into dependent, independent, and then dependent. So dependent costs a lot of money. For example, in the UK, and I'm sure in India, to look after a patient who is fully bedridden, you have to comb their hair, brush their hair, turn them, toilet care, bowel care, dressing them up, teeth care. All this will cost at least 25 to 30,000 rupees per month, depending upon which city you're living. In the UK, because of social care, the cost for the dependent people can be anywhere between 25 to 30,000 pounds a month. So the cost of healthcare is huge with stroke. So we all know this as anesthetists. We are very good at this. We know what is the blood supply to the brain, the gray matter and the white matter. The gray matter requires more blood supply. And this is the glucose utilization. As you can see, the glucose utilization in CMRO2 is 3 to 5. And this glucose utilization is very, very high. So it's an obligate glucose. It needs continuous oxygen and glucose supply. Okay. So the terminology which we have now gained are, we know what is NIHS, we know what is FAST, we know what is sticky score, we know what is Alberta score, we know what is modified ranking score, we know what is large vessel occlusion, which is ICA, MCA, anticerebral artery. The other things I would like to introduce now is by the time the patient comes to the door and has a venflon or a cannula in to give thrombolysis, that is door to needle time. And then gets out of the small hospital. So there is a door in and door out time. This is the CT angio to groin puncture time. So from the CT scan to groin puncture time, we will measure. And this is called LWK, or the last well-known time. And then wake-up stroke is sometimes in strokes, patient can wake up with stroke. Unlike myocardial infarction, because of pain, patient can get up, or because of shortness of breath and sweating, patient can get up and come to hospital, whereas stroke, they might even wake up as with stroke. So we do not know what time the stroke started. The other thing is called SICH, which is symptomatic intracranial hemorrhage, which is a complication of alteplase and blood-brain barrier malfunction. So this is the middle internal carotid artery, middle cerebral artery coming in. That is the corona radiata, and internal capsule is here. This is where the various arteries come and feed. This is the lenticulostriate arteries. This is where you will get dense hemiplegia. So it's divided into various branches, M1, M2, M3, and M4. If the clot is here, it is nice and proximal, easy to remove. As the clot progresses, it is more difficult to remove. Large clots will be here, and they all will need thrombectomy, whereas clots which are here may be dissolution, can be diluted with alteplase. So this is the anatomy that we are interested in. So I would like to introduce also this. All of you know what is normal blood supply, normal cerebral blood flow. You know, as the blood flows slowly, it comes down. There can be irreversible damage. This irreversible damage will lead to what is called an infarct, and the infarct core, which you cannot do anything. But there is an area of penumbra which can be reversible. That is because of collaterals and various type of circulations and type of people. There is still a penumbra which has got decrease in blood supply or suboptimal function is going on, but it can still be rescued. All right. So that is what we are interested in. So mechanism is keeping injury. So within about exhaustion of cellular ATP within 4 to 5 minutes. So this is really quick. Okay. Loss of blood supply in 0 seconds. By 4 to 5 minutes, there is death of cells and an infarct core develops. So this is the oxygen extraction fraction that we are talking about. So the orange is where the core is. And as we progress towards the right, as you can see, less than 12 ml per 100 gram per minute, you get infarct core of some 50. If you reduce to 12, you get a nice infarct core, which is not, you cannot reverse it. So Saver in this stroke journal provided this. If you per stroke, you can per second and per minute and per hour, you keep on losing neurons, yeah? Nearly 1.9, 121 billion neurons are lost. And if you project it for aging, you age so much quicker. This is functional aging, yeah? Not in chronologically functional age. You age 8.7 hours. So quickly all your functions are lost. So stroke can be really devastating, as you can see from this. So the concept of time is brain, because this is born, this phrase is born from this paper. So time is very important, as we all know, for the brain and its blood supply and the oxygen supply. And because of this new treatment, there was a revolution in acute ischemic stroke care pathway, and it caused very big changes compared to medical treatment alone. So this paper compared endovascular treatment versus medical care alone for stroke. As you can see, in the year 2013, there are these 3 trials, and you can see the forest plot. It doesn't favor, it's all neutral. It's still not very good. But in 2015, if you look, there's 1, 2, 3, 4, 5, 6, nearly 5 trials to 6 trials were published, and it clearly showed favoring endovascular treatment. So that's a big leap in treatment. From 2013 to 2015, you can see there is a big treatment favoring endovascular treatment. So these trials were published in the New England Journal of Medicine, Mr. Clean, Extend 1A, Escape, and there is REVASCAT and SWIFT Prime. All these trials proved that endovascular treatment is far, far superior to medical treatment alone. If you see the overall population, this is the overall population. This is how the white box is MRS 0 to 1 to 2. That means they are fully functionally independent. 1 also less independent, and then 3, 4, 5, 6. 6 is death. 5, they are dependent. 4, they are dependent. So we are looking at 0, 1, and 2. That means they are fully independent. So look for modified ranking score of 0, 1, 2. So here, if you see, the control population is only 5, and then intervention population is 10. So there's a definite benefit. Even in people who are not eligible for alteplase, they may have a contraindication because they are allergic, or they are very hypertensive, or they had recent surgery. The benefit is very high. See, there is 10.2 here, it's only 3.6. And people who have even received alteplase, the benefit is very high in the intervention prevention. So there is no doubt that stroke thrombectomy is superior to medical treatment. Now, a highly effective perfusion. There is a group which were interested in all these trials, and they came up with more data showing this, which favors, they put in various age criteria, aspect criteria, stroke location, NIH score, and from the onset, both for more than 300 minutes and greater than less than 300, more than 300 minutes, and they showed it favors intervention. Okay, and the number need to treat is coming to around 2.6. Now, no treatment in non-communicable disease has achieved a number of 2.6. It is very difficult, other than antibiotics, to find such a treatment for any disease. So NNT of 2.6 is really dramatic. As soon as you see this, every government and every healthcare institution should work on this to offer the treatment, so that the burden on the healthcare of the country and the family is reduced. Next slide. Okay, so if you see mechanical thrombectomy 2.6, carotid endarterectomy is a fantastic operation. It's still NNT 7, so very good operation. IV thrombolysis, which I've been talking about, again, that's very good. It's 3.6 to 19, depending upon the time you come for stroke. And PCI, or cardiac stenting, or PCI, is still 30, very high to prevent death. So 2.6 is a fantastic number to achieve, and stroke thrombectomy is going to change the treatment in future in all the countries in the world. So in 2016, these were the indications. You were 18 to 80, we had a stroke and large visual occlusion. If you come within 0 to 6 hours, and NIH is greater than 6, and aspect score is greater than 6, you were subjected to thrombectomy. If you see the American Heart Association classification guidelines, for mechanical thrombectomy for 0 to 6 hours, it is level 1 evidence. So time is brain. You have 0 minutes and hours and days, you get a full infarct. So time is very, very critical. Otherwise, the infarct is going to grow and grow. So in this JAMA journal for time to treatment for endovascular thrombectomy, you can see it's a very important slide. If you see on the y-axis, time is moving from 180 to 43 hours, 4 hours, 6 hours, it's going up. This is the x-axis, the percentage of patients. So if you As you go up, you can see this, you can see the percentage of patient coming down. So by 180 minutes and 240 minutes, you can see it's going down and down. So timing is very, very important. The earlier the patient comes, the better is the modified ranking score. Once again, modified ranking score is 0, 1, 2. This is the benefit we are looking for. 3, 4, 5, 6 are 4 and 5 are dependent, and 6 is death. So here you can see, even once you come to the emergency department, this is 60 minutes. This is the percentage of functional dependence. It rapidly comes down. Once you come after 180 minutes, there's rapidly come, but still there is benefit. And this is the line of no difference. About 270 minutes after 60 minutes, there is no benefit. And this is also after CT scan, you need to have yours. Around 300 minutes, there is almost no benefit. And here is from, so this is for 3 months for endovascular. This is looking after 3 months, that is 90 days after disability. You can see for about 7 hours and 14 minutes, there is no benefit. So you can come up to 7 hours if you still have an intervention. This is the line of no benefit. Up to there, you have benefit which favors thrombectomy. And here also it shows whatever MRS, all the MRS scores 0 to 5 can be achieved if you come early. So earlier groin puncture or femoral artery puncture will favor good outcome. Now, the patients, when they're coming through ambulance, either they will come to a small hospital or a district general hospital or an acute stroke center, or they can be taken to a big hospital called a comprehensive stroke center, which can do intravenous thrombolysis, mechanical thrombectomy, decompressive craniotomy, and ICU admissions. Now, there is a confusion. What will the ambulance do? Go straight to the big center or go to a small center, receive thrombolysis, and then go to a big center? These are all debates that the network will organize depending upon where the patient location is. Is the big hospital nearer? Is the small hospital nearer? Depending upon the stroke severity, they will make this decision which hospital to go. So either you can have a mothership model where you come straight to the big hospital, or you can have a drip and ship model where they go to a small hospital, get their CT scan done, put the cannula in, get the alteplase, and then ship them into the big hospital. So when they do that, so this is, they come into a small hospital from door to their through the thrombolysis to their cannula time is a door to needle time. Then once they leave the small hospital and go to a big hospital, it is called the door in and door out time, or they can come straight to the angiography suite in the big hospital, that is door to door time. Once they come into the angiography, we are measuring the door to the arterial puncture time. Okay, or they come to a big center, door to thrombolysis time, and then hub to the the arterial puncture time. So these timings are very, very important. Where the ambulance goes, how much time we take to do CT scan, how much time we take to give thrombolysis, how much time we take for thrombectomy. All these are very important times. So for every 4-minute delay in the accident and emergency unit or the casualty, door to reperfusion, 1 in 100 will have a bad outcome. For every 1,000 patients, for every 15 minutes faster A&E door to reperfusion time, 39 patients would have less disabled outcome at 3 months, which is very important. So just 15 minutes, 4-minute delay, 15 minutes faster, an additional 25 would have a functional independence. So these are very, very important timings published in this journal. So what about strokes which are not witnessed or stroke after you wake up? Okay, so there are some trials. These are the diffuse trial and diffuse trial for 6 to 16 hours. And then if there's a dawn trial, which you will get up to 6 to 24 hours, 6 to 16 hours, dawn trial and diffuse trial will be 6 to 16 hours. So even later, if you come, there is benefit for endovascular therapy. So in the AHA Association guideline, even for 6 to 24 hours also, there is level 1 evidence. I'm not going in detail into both the dawn and diffuse because it's more of a neurologist thing. It is not. And what they do is advanced imaging. They just don't do a plain CT, but they do CT perfusion or MR diffusion, and they look at the core volume. Yeah, this is the volume, infarct core volume. And they look at the volume of the penumbra and the core and take a ratio and the volume and the age, and then make a decision whether they should have thrombectomy or not. So when they come, this is the dye they inject, the slope, and the dye comes out of the brain. It all takes up in seconds. So the slope of that will be the cerebral blood flow. The area under the curve will be the cerebral blood volume, and the time for the RBC to reach the peak of the brain will be the time to peak, and then you've got maximum time to exit the brain. So all these times are computed, and then you get a picture like this of perfusion, just like the PE scan. You get where the defect is, where the perfusion is, where the blood flow is, and then the core and the penumbra are differentiated between these two, and there is a ratio between these two, and an indication is done. Now, for indication for thrombectomy was between penumbra and ischemic core greater than 1.8, ischemic core should be less than 70. However, these things are all changing. This is just for our knowledge of what is happening and what the neurologist and the radiologists are doing. So we have a national guideline for stroke now, in 2023, and how ischemic stroke actually. So much has changed. As you can see, all the age limits have gone now. Even 80, 85, 88, even 90-year-olds are being treated. More than 4.5 hours window is there for wake-up stroke, and unknown onset up to 9 hours. You can have treatment, and known onset time more than 9 hours. So what I'm saying is the hours are being pushed even more. Even if you come late, treatment is being offered. And the imaging criteria, still it is less than 10, but this has gone to 1.
Recording in progress.
So many people benefit. And so there is also automation in imaging, where you can bring artificial intelligence. So much of data coming, every patient comes very quickly. So much data and imaging data and patient age data is there. So artificial intelligence is being used. There are two softwares. One is Brainomics and the Rapid AI. And these trials are being fed into all these softwares, and you get the physician will get an update immediately once the patient factors are entered and the imaging is entered. You get where is the infarct, how much is the penumbra, what is the core volume. You don't have to interpret the whole thing, which will take time. So this software does it for you, and all the trials are being fed into this as clinical validation. And on the mobile phone, both the stroke physician and the anesthetist, we don't have this, but the stroke physician and the intervention radiologists will get this, so that they can plan very, very early. So all these are being done very early. It's a mobile app. You can open it and see your patient. Even if they are in a small hospital, you will receive information early and you can plan. So all this is possible because of new types of devices. All these are the new type of devices which are being now sold, just like various generations are there. There are new generations of devices depending upon the anatomy. I'm not going to go into there are two types, stent retrievers and aspiration catheters. So let's skip all these things. This one I'm showing between these two devices. What I want to show is some of the best centers where you get groin puncture within 17 minutes of room arrival, and the time from groin puncture to reaspiration is 25 minutes 30. So these are all very, very good centers which have produced these results. This is the closure device. Once the cannula, once the femoral artery puncture is finished and the whole catheter system comes out, they close the femoral artery puncture with this device. These are the risk factors for stroke. You all know it. I'm not going to go through this. So various specialties are involved in this. This is the ambulance, the accident and emergency or casualty stroke team, anesthesia team, CT team, transport team, intervention radiology, suite members, radiographers, radiology nurse, anesthesia technicians, intervention neuroradiologists, recovery staff, intensive care staff, and the stroke ward staff. So it's a huge team working on this. Unlike hernia or appendectomy, where only one or two teams are there. So this is the suite where they all work together. And anesthesia for thrombectomy, what we do is it's an emergency. So you need to do a pre-assessment. We can't do that very much. Very less information will be available. Consent has to be taken. We always consent for cardiac arrest, the full AGBA monitoring, pre-oxygenation, rapid sequence intubation. You can either use sevoflurane or TIVA, or just sedation alone. Blood pressure should be maintained between 140 and 80. We don't put an arterial line unless they have cardiomyopathy or very valvular heart disease. No catheter, warming, good blood glucose control. We give Filovate and extubate, especially without aspiration, because aspiration is one of the commonest cause of deaths in all very sick, frail, and post-stroke, post-thrombectomy patients. Anesthesia, It's an emergency where you take quick history, look at the comorbidities. You can either give a local anesthetic or where you do nothing and they take over if the patient is very cooperative, or some patients can be very agitated, they need sedation, or some people where the thrombus load is very high, the carotid is very tortuous, and the patient is very unstable, and the intervention radiologist is very junior, they all demand general anesthesia. So GA is very, very useful for this procedure, which is very commonly used now. So before conscious sedation versus general, it was before thought that GA is very bad because we cause hypotension, and all observational studies showed that sedation is much, much superior to general anesthesia, and general anesthesia was frowned upon because of this bad outcome with GA causing hypotension. Now, so we were waiting for a randomized control trial. This is the Goliath trial, which came from Germany. And this is a single center trial, which showed, I'm going to go in between conscious sedation and general anesthesia. If you see the 90-day MRS score here, it's 2 and 2. That means it says that general anesthesia is not inferior. In fact, it can be better. It can be even better for thrombectomy. So general anesthesia is slowly becoming better than conscious sedation. Now, if you look at the neurology, this paper which came out recently in 2023, which compared endovascular thrombectomy versus non-GA, and these are all the trials: Siesta, Anstroke, Goliath, Canvas, and all these trials. These are the various techniques. Different people use different techniques, and this is the summary of everything. Siesta, Anstroke, Goliath, Canvas, all these are single center study. From China, again, single study, and then France made this gas study, which is around 4 centers. And now we have very good evidence saying that GA is safe and superior. It can be used. Now here, if you see, it can be, it is good if you take A, B, C, and D. A is for recannulation success, B is for good functional recovery, 3 is for mortality, and D is for hemorrhagic complications. For everything, GA is favored. So GA is well controlled, and it is a standard of care. Now, we can also use sedation and no sedation or just local anesthetic in the appropriate cases, but GA is not harmful as it was thought before. Right. So, so now GA is established an effective and recannulation group. There are class 1 studies, and this one summarized that it should go into the guidelines with GA as level 1B. So there is good evidence. So even for GA, we have level 1 evidence, and for thrombectomy also we have level 1 evidence. Now, some people thought that we should not do thrombolysis. This study clearly shows that you should give TPA first and then thrombectomy. It is definitely beneficial. So not straight for thrombectomy. If there's indication for TPA, we have to give thrombolysis also followed by thrombectomy. So this is the flow pattern. You have a stroke, and then with an onset, they have CT head, or if it is 0 to 6 hours, no need for advanced imaging. If you come after 6 to 24 hours, 64, you have more advanced imaging, and then mechanical thrombectomy. So the main thing I want to show here is 0 to 6 hours, no need for advanced imaging. After 6 to 24 hours, you need more advanced imaging to find out what the core is doing. Fine. These are the advantages, disadvantages. Advantages are patient is totally mobile. Disadvantage, there'll be a lot of hemodynamic fluctuations compared to when you compare GA and conscious sedation. So regarding blood pressure, these are the, even a small decrease in blood pressure is damaging. If you keep MAP greater than 90, you can see more people are benefiting the rate of good outcome. If you keep the MAP less than 70, there is a decrease in rate of good outcome. So blood pressure has to be up, the most important factor. So the guidance is not very clear. It's still only level 2 evidence. If the blood pressure is very high, you have to bring it down to 180 over 105. What everybody is scared of is the hemorrhagic transformation if the blood pressure is very high, which will increase mortality. So there is still not very good evidence, but evidence is slowly coming. One trial which I want to show is the Enchanted trial, which came up in Lancet. They compared 2 types of blood pressure during thrombectomy. One is a very free blood pressure around 140 of less intensive. This is the blue is the more intensive control around 120. This is the diastolic. So one group is high, one group is low, which is intensive. If you compare this more intensive and less intensive, in less intensive group, the outcome is greater. So, and this trial was stopped earlier, okay, because people were going into poor outcome because of severe blood pressure control. So leave more intensive control and just do less intensive control. So these are the other randomized control trial, BP Target, Enchanted, Best, and Optimal. And all these groups advocate do not go into very low blood pressure, do not have very high blood pressure. Stay somewhere between 140 to 80 is what is recommended. So there is always controversy regarding this. The latest editorial shows that 140 to between 140 to 180 is a comfortable, and we have to personalize the blood pressure depending upon how the patient is because of various other comorbidities. So we can also, regarding the type of anesthetic, so blood pressure we have tackled. Now type of anesthetic, we can either use Tiva or sevoflurane, or you can use sedation. So regarding comparing this is a retrospective trial which came from Dubai, and this showed that inhalational you get only 12 and Tiva you get 18. So there is some evidence that in retrospective analysis, Tiva is looking better. But I wouldn't, this is wrong way of presenting. This is because it is retrospective. I'm just trying to show you that you can use different methods. And in this, Tiva is shown, and I've got a bias towards Tiva. So next, when we come as an anesthetist, we are going to induce in the anesthesia room. It will all be rapid sequence for all patients, whether fasted or non-fasted. You can use opiate, remifentanil infusion. No need for intra-arterial blood pressure monitoring. You can just use blood pressure, maintain with oxygen air and sevoflurane. Some patients are very elderly and frail. They will need very less MAC, but maintain blood pressure between 140 and 80. So you need metramidol infusion or ephedrine infusion or whatever vasopressor you would like to use. Post-operatively, extubate and send to the stroke ward or intensive care as the case warrants. Sometimes the neuroradiologists will take a very, very long time in this. So this trial, which I got from the cardiology, so if the procedure takes 15 minutes, 30 minutes, 60 minutes, and then 90 days. I'm sorry, more than 60 minutes, right? You see this red bar. The red bar is there. The red bar is increasing. It is increasing. So the longer the intervention radiology spends, more than 5, 6, 7, 8 attempts, the complications gets more and more. The complications being hemorrhagic transformation and intracerebral hemorrhage. So we should try and bring the radio. They start enjoying once they are into the cerebral thing, they try and get the best picture. Oh, I need more attempts, but this will create harm. So first attempt is the best attempt, just like our laryngoscopic attempt and difficult airway. Only 2, 3, or 4 attempts should be good. You should be able to get it. Otherwise, you're going to cause more harm. These are the various complications all of you know because all of you are doing various procedures, vasospasm, hematoma, hemorrhage, all these, and anaphylaxis can occur. And then also contra-induced nephropathy, anybody who's got diabetes and greater than 75 years who are using non-steroids and previous renal impairment. The other thing which we are involved is the decompressive craniotomy. Some patients who may progress into this if they are not treated very well or they come late, there is the whole middle cerebral artery in a region can go into infarct. They can drop their consciousness, drop in an NIHS score, which will lead to herniation and death. So we are involved in this. They are rushed as E1 into the operating room for decompressive hemicraniectomy. And there is good evidence that surgical produces better outcome in these patients. And this is the outcome if you get an NNT of 2 for survival and MRS score less than 4, NNT of 6 for survival and MRS score less than 3. So definitely below 60 years, it is advocated. Over 60 years, you'll have to do a detailed discussion with the family. And though the benefit, in fact, patients might be living longer, but they'll all be dependent and in a vegetative state. So you should have a clear discussion with the family. So there is a 23% greater chance of MRS at 3 at 1 year, 42% reduction in mortality. So it is definitely beneficial in patients less than 60. So how to measure? We're all doing all these things, but how do we measure quality? It's all very important though we do so many things, but are we doing the right thing? So this group created a consensus and regarding quality and benchmarking. This is a very busy slide. I will break this down for all of us. So the standard should be from door to CT scan, 75% of the patients within 30 minutes. In best centers, within 12 minutes, you'll get a CT scan within 30 minutes. CT to groin puncture time, that is the femoral artery, 75% patient should be within 110 minutes. In good centers, less than 50 minutes. CT to groin puncture time, okay, in should be less than 80 minutes if imaging already done. So when the patients come from other hospitals or small hospitals, they already will have the imaging. So we should be even quicker in that. If this is with imaging in our hospital. Now in Tiki score, as I told you, should be greater than 2B within 60 minutes. And no more than 10% of your patients should develop symptomatic intracranial hemorrhage. And of all patients treated, at least 30% should be independent with an MRS score of 0 to 2 after 90 days. So this is very, very important. If we are not hitting this 30%, then we have to reevaluate our service and make changes. So this is the American Heart Association. They are very, very strict, okay, this is for thrombolysis. Within 15 minutes, a neurologist should see. Within 20 minutes, CT scan. Within 45 minutes, integration neuroimaging. And within 60 minutes, then you should get your thrombolysis or a clot-busting drug. Now, for small hospital or acute stroke centers, the door in and door time. If you can't do a thrombectomy, you just give thrombolysis. You should go into the hospital, get your diagnosis, get your cannula, do your CT scan, get the cannula, get alteplase going, and get out of the hospital within 45 minutes and come to a major center for thrombectomy. So the other standards are, there should be all cases of symptomatic should be reviewed. And then all patients have an NHS document over 24 hours. And MRS at 6 months should be more than 45%. So these are the various standards we should be constantly auditing and benchmarking and improving our service continually. So these are the key audit that we all perform: 30-day post-treatment mortality, time from onset to major thrombectomy center, and time from arterial puncture to mechanical thrombectomy. Yeah, okay. So our hospital was the first to produce in the whole of United Kingdom in 2014. We were doing this. This is published in 2013. So first mechanical thrombectomy ischemic stroke was serious produced from our hospital. And we had a good clinical outcomes in more than 50% of the patients in severe strokes. And then in 2019, our hospital produced this article where they compared out of service and the daytime service and whether the out of service is safe or not. So if you look at this timings of the hospital onset to door, that is from the symptom onset to door coming to hospital is 109 minutes. Okay, this is in hours and this is out of hours, and door to CT within 23 minutes and 21 minutes in hours, out of hours. CT to groin is 104 minutes. That is very long. Procedure time is 55 minutes. Door to groin time, that is from patient coming into the hospital to the groin time, is 124 minutes. So almost 2 hours it takes. And door to procedure end is almost 3 hours. So the whole thing takes around 3 hours to finish. I'm sure we can improve on these. And these from 2010 to 2019, this 2019, so I'm getting only till June, so only half. You can see the number of cases increasing slowly. It is increasing up to 86. And you can see functional independence was 9%. It is slowly going up to 39%. So we are hitting the 30% mark, which is very good. And from door to groin time, it should slowly decrease. It's come down to 108 or 100 minutes, 118 minutes, it's come down to. So we are slowly improving, and there can be more done. And it is comparable to various trials as well. So this is the June 2022 comparing to June 2023. Again, our mortality is 0 here. Mortality is 9% there, and door to CT time was 17 minutes. Door to CT was 12 minutes in June, and CT to groin was 65. And all these are very good. I don't want to bore you with all the statistics. Even our OH is out of our cases. Door to CT 42 minutes, and average was 34 minutes the next year. And this is similarly in July. Also, door to CT is 22 minutes. So the timings are slowly improving, and which we can do better. So this is what we aim to achieve. Door to groin puncture 60 minutes, door to groin puncture 45 minutes, groin puncture deployment of device less than 30 minutes, and to full reperfusion less than 6 minutes. This is what we are trying to achieve, and we are benchmarking to this and auditing our practice. So these were the statistics from 2019 to 2023. Onset to door, our mean was 160 minutes, door to CT 25, CT to theater 49. We are able to give anesthesia within 10 minutes, anesthesia to groin puncture within 28 minutes for putting on the table, preparing, draping, and all those things. And from groin puncture to end of thrombectomy, they're able to achieve in less than 30 minutes. So what did all the patients come from? They came from our neighboring hospitals. So more patients come from our own place, and these are all the neighboring hospitals. So the first case, UHNM published in 2015 in UK. 2015, all the trials level 1 evidence came. And 2016, there is a institute called National Institute of Clinical Excellence, which gives all the various treatments and the recommendations to whole of UK. And then UHNM was, sorry, I'll go back to that. And UHNM was awarded 2 hospital journal awards for saving the health economy. That is one title. And then producing improved clinical outcomes. So for health economy and for improved clinical outcome, we were awarded the best performing hospital award for that. And this is our stroke thrombectomy team, the radiologist and the stroke physicians and the radiographers and the nursing staff. This is our consultant, Gahan Bose. This is Sanjeev Nayak. He's one of the very famous interventional neuroradiologists. And this is the team that performs the thrombectomy. So workforce, we have interventional radiologists. There are 3 or 4 of them, neuroanesthesiologists, 1 in 7 now. We were 1 in 5, 1, 6, and 7. And stroke physicians, they are 1 in 8 on call rota. That's what they do. This is our stroke ward. It is a 28-bedded ward, and they've got 8 consultants. And the national mortality, if the thrombolysis rate is 11%, our hospital is around 17%. And the mechanical thrombectomy rate is 2.8%, which is higher than the national. I do not want to go into various details at this moment. Okay. So regarding mortality, this is very, very important. National is 33% back to independent living, whereas our hospital is above the national average. And post-thrombectomy mortality, national is 16. Our UHNM is 14.7. So we are definitely doing better than the national average. This is the scenario in UK. About 150 hyperacute stroke units. There are 90 interventional radiologists, around 80,000 strokes per year. There are 24, I think, 4 interventional radiology centers who can do mechanical thrombectomy. And UK needs around 11,000 MTs, mechanical thrombectomies per year. So actually, many people are missing out because services are not available 24/7 or even late in the night. And many places, radiologists and scanners are not available. So many people are missing out. If you take Europe, this is the stroke incidence, red area, Turkey and Greece and Italy. The stroke incidence is very, very high. You got intermediate in, in United Kingdom, Scandinavian incidence is very low. This is the thrombolysis rate. Again, the red areas are very bad. Germany is doing very well, and Scandinavia is doing well. UK is just doing just about okay. This is the endovascular treatment for thrombectomy. This was old data. The red people are doing very badly. Germany is doing well. Portugal is doing well. And then Scandinavian countries are doing well. UK is not doing well in thrombectomy. It is still in red. There's so much to go. So there is a long-term plan for NHS. What they want to achieve is by 2025, they want to achieve the best performance in Europe. And by 2022, by 2022, they want a 10-fold increase so that each year, 1,600 more people will be independent after their stroke. So for implementing this new pathway, there is a National Stroke Guideline. There is also the 9th report of the Sentinel Road to Recovery audit. There is the implementation guide for UK, and there is a framework for the West Midlands region. All these will be the pillars for improvement in these services. From this report, we can see the various places in UK, 13% of thrombectomy, 14%, 9%. Okay, so the south of England is doing very well, and the proportion of thrombectomy is slowly increasing. Only 20% are doing 24 hours a day, 44% office hours, and 36% extended. So all these have to do 24/7 to improve the numbers. Some are maintaining quality standards. Brain imaging is done within 55 minutes, but there are various standards which are being also deteriorating. There are standards which have improved, which is the thrombectomy rate from 1.8 in 2020 to 2.4%. So that is very good. So some standards are improved, whereas there are some standards which have deteriorated. This is the national standard from 89 minutes, 90 minutes it takes. This is all during COVID time, so it took more time from onset to arrival, from arrival to thrombolysis. So within 60 minutes, many are receiving thrombolysis. This is how the various wards, this is the hyperacute stroke unit where you have 24/7 consultant available, whereas in acute stroke unit, it is only 5 days a week. So that's how the system is being implemented. So this is England, which is 56 million, and West Midlands is 2.9 million. So this is the area that we are covering. 2.9 million is the population that West Midlands is responsible for. And this is Stoke-on-Trent, where our hospital is. This is Birmingham Hospital is here. This is the area that is being fully covered. As you can see, this is a 24/7 thrombectomy center here, another 24/7 thrombectomy centers here, and all other hospitals will be hyperacute or acute stroke units. So this is the ambulance time, okay? All the orange ones will take a very long time. By the time ambulance reaches the acute stroke unit, hyperacute stroke unit will be more than 60 minutes. All the blue areas, they can reach within 10 minutes. All the other areas between 20 and 29 minutes. So your region and the ambulance distance will determine the type of outcome you get. So here you can see the amount of thrombectomies we're doing. This is 2017-18. This is the projection. This is the Stoke-on-Trent Hospital here. 63 we were doing, and it is slowly going up. It is going up to 67, and it is projected grand total of 167. It is going, it is 133, sorry, 63 here, and it is going to be 133. So a good, big increase. I can tell you by December, we have already done around 187 thrombectomies in this year. So definitely it is going up. That means other hospitals are sending patients much earlier now. To come to our hospital, it will take, from this hospital, it will take around 52 minutes to reach from various places, 69 minutes, 52 minutes, whereas through helicopter service, air ambulance, it takes only 10 to 15 minutes to reach the hospital. So you can gain more time. So there is a hospital there is a new helicopter service available from the other smaller hospital, but this is available only in daytime so that vital minutes are saved and the outcome gets better. And you just can't do only thrombectomy. In primary care, this is the goal for the nation. You get atrial fibrillation, high blood pressure, and high cholesterol. All these have to be controlled. So by 2029, 85% of the people with AF will be detected. 90% will be on adequate anticoagulation. You need to reduce people's blood pressure. By 2029, 80% of the blood pressure will be diagnosed and reduced. And cholesterols, 75% of the people by 2029 will get their cholesterol reduced or have a cardiovascular risk assessment. So primary healthcare also, you have to intervene in a timely fashion to reduce the amount of stroke you get. So Saving Brains is a document which tells about various services in this place. So England is doing 2.5%, whereas USA is doing 8.5% of all thrombectomies. That is very, very high. Other countries are high. England is still very, very, very low at the moment. It has to increase. Now, nearly 5,899 patients have missed out on the treatment. Nearly 52% of the stroke units have a consultant vacancies. And all these are various problems. 42% of the stakes are not scanned within 1 hour. And the UK has to spend nearly 400 million, and that would be cost a saving of around 1.3 billion over 5 years. So money has to be spent so that you can save on rehabilitation and rehab care. So these are the 3 guidelines which we use: 2023's National UK Stroke Guideline, the AHA American Guideline, and the European Stroke Organization estimate guideline for treatments and for the pathways. This is Maharashtra. Maharashtra's population 127 million, and Mumbai population is 20 million. How the Maharashtra government and the health minister will organize the scan centers and thrombolysis centers, how you will get quickly to hospital. This is a major planning I'm sure every state and every city will do on itself and will treat its patient to get the best possible outcome. So, conclusion. The evidence for mechanical thrombectomy is very, very high. UK needs around 11,000 mechanical thrombectomies per year. You need to totally reorganize the stroke services, and there should be increase in training of staff. Some of the general radiology consultants have to be trained in intervention neuroradiology as well. And of course, the spending has to increase so that you can save money later. That is all I have to say. Thank you so much for listening. Thank you.
Oh my God. I'm not able to open. Dr. Albin, excellent presentation. Excellent, very good.
Thank you.
You have not only told us about management, but whole statistics. I think we'll come to questions afterwards.
Yeah.
Statistics and how should we improve practice.
Yeah.
Very good, very good. Thank you. So now we'll move to our second presentation, which is by Dr. Vinod Gadiyar. And I'll just share my screen. Can you see this? Can you see my screen? Can you all see my screen?
Yes, madam. Yes.
So our second speaker is Dr. Vinod Gadiyar. Yeah, he's a consultant in anesthesia and pain medicine in Fairfield Hospital, Northern Care Alliance group of hospitals in Manchester. He did his MD from Kasturba Medical College in Manipal. He's been practicing as a consultant in the UK for the last 27 years, and he has special interest in chronic pain. And he's an educational supervisor for foundation doctors, anesthesia trainees, revalidation and appraisal lead for the hospital trust. He's an elected consultant committee member of British Medical Association in the UK. And he is a chairman for British International Doctors in the UK, Rochdale and Bury Division, and national treasurer of British International Doctors Association in the UK. So Dr. Vinod Gadiyar will tell us about processed EEG. How do we monitor, and he'll tell us in detail about monitoring of neuromonitoring, other processed EEG and BIS monitoring, and how should we apply that in our clinical practice. Over to you, Dr. Vinod.
Yeah. Let me share that. Okay. Can you see my screen, Vaishali?
Yes.
I can't see myself, but that's all right. That's all right.
We'll be seeing you.
Yeah. Okay. Thank you very much, Vaishali, for inviting me, and thank you for your kind introduction. I want to say what a fantastic talk we have had by Albin. I hope I can live up to the expectation on my talk here. And congratulations to him for winning a accolade in the country for their service. Okay. Thank you also to the office bearers of and members of ISA in Navi, Mumbai. I've not been to Navi, Mumbai other than passing through, but now that I'm connected, I would like to come and visit you. Greetings from sunny Manchester. It's winter here now, but today we have got very good temperature of 11 degrees, which is higher than usual for this time of the year. And it's sunny as well. And I'm delighted to do this talk to the August audience. And I'll try and keep my talk to as simple as possible and user-friendly for a general anesthetist. And please ask me questions, which I will try and answer at the end of the presentation today. So I will just go through this talk on following headings. My talk is only for about 20-25 minutes. I'll just do a quick introduction, EEG waveforms, touch on depth easy and what is by the monitor, ECG indices, spectrogram, and how to make most of the EEG to administer a safe anesthesia, and some conclusions. So I don't have any declaration of interest. I want to say that I'm not an expert in EEG, nor am an academic. I'm just a simple jobbing anesthetist. The story about use of EEG started in 1937 when it was thought that EEG can be of help to measure the depth of anesthetic. And the processed EEG, which was to do with the spectrogram, was done for the first time in 1971. So I'm not talking about anything that is new here, but what has happened is we have had interest in preventing preventing the awareness under anesthesia. So I put the depth of anesthesia here within inverted commas. That meant that whatever you do, it's only a surrogate marker, and EEG is one of the things that we can use to prevent awareness and also to measure the depth of anesthesia. So there are four bits that I'm going to talk about today: raw EEG and processed EEG, spectrograms, spectral edge frequency, and various indices. Okay, I'll go slowly and just to talk about each of them. So this is basic actually, which is talking about EEG waveforms. Now, this is cricket, isn't it? Most of the times we think of cricket, yes. And in EEG waveforms, I think it's good to think of cricket. So it's a small mnemonic that I have. If you win a toss, you just want to bat first, isn't it? So get batted. So from the bottom here, G is get batted, BATD. Okay, so that's how to remember. So the waveforms are measured by number of beats in a number of amplitudes in a second. So if there is only one, like here, is 1 hertz. If there are 5 in a second, it's 5 hertz. If there are 8 in a second, it's 8 hertz. So if you look at from the bottom again, get batted, gamma waves. Gamma waves are at a frequency of 25 to 30 or 35 up to 80 actually. So, and then there are beta waves. So in a second, you can get between 12 to 25 or so. Then the alpha waves. Alpha waves are from say about 8 to 12, and then theta waves and delta waves and slow waves. So I'm going to talk about some of these waves as we talk about depth of anesthetic and how we use EEG. Okay. So from the top here, we got a awake patient who has got this kind of waveform, which is mostly gamma. And as the patient gets into anesthesia, slow induction of anesthesia, there will be a bit of paradoxical excitation, and you can see the waveform is changing. And this is mostly beta oscillation. Okay. And the patient becomes even deeper, and the alpha starts to appear along with the low beta waves. And the patient achieves unconsciousness and surgical level. You get slow beta as well as alpha oscillations. So alpha meant, as we were talking about, per second, about 8 to 12 waves. And once when the patient is unconscious at induction of anesthesia, you'll see these waveforms like waves in the sea, which is delta. So delta is lower in frequency, maybe 1 to 4. So if you have anesthesia even deeper than that, that is when we get the waveform here, and that is called as burst suppression, because the whole of the EG is suppressed and you will get almost like a line, but in between there is burst. So if that is why it's called as burst suppression, burst and suppression. And then even deeper levels, you can get complete isoelectricity like a flat line. Okay. So in clinical practice, what we do is we measure the frontal EG. So this is one of our trainees. We put, this is a BIS monitor that we are using. So the electrode is placed on the forehead. Before we put the electrode, we have to nicely clean the area so that we don't have any problem with the impedance. And then it is connected to the monitor. So electrodes are placed over the forehead to record EEG from the frontal lobe. Then the EEG is being transmitted onto the monitor. There is a process there called as fast Fourier transformation, which dissects this waveform into principal components of frequencies. Say, and there is a number that is derived from these, and BIS is one of them. So you may be using BIS. So BIS has got a number from 0 to 100, and I'll talk about that in a minute. So there are variety of monitors which give an index number. And then there is also how a mathematical model which also gives you a power spectrogram. Okay, but whatever you do, I think one has to correlate the clinical findings with these parameters. You can't say that the BIS is high, so the patient is light. No, you have to look at all other things. Okay. So now let us look at the monitoring, why we are using frontal lobe, or why we are, how it helps us to measure the depth of anesthetic as such. So at the front here, we have got a frontal cortex here, and one in yellow is the thalamus. So most of the times the thalamocortical pathways are very, very active. And once when there are cells in the cerebral cortex, which are called as pyramidal cells. They are like a cone with the top like a dendrite. So they are all parallel to they're all parallel to each other, and they're perpendicular to the scalp. So that renders it to be a very nice so they are very available to have the EEG being monitored. So you can see a scalp electroencephalogram waveform which is measured from the frontal lobe of the cerebral cortex. But just there's a question. Yes, if the thalamus is so important, why is that we can't measure thalamus EEG? Because it's quite deep and it is very difficult to measure the EEG from thalamus. However, because the cortico-thalamic pathways are so robust, and when we depress the corticothalamus pathway, whatever we are looking at, the cortical EEG is probably a measure of what goes on in the area of thalamus or in the midbrain. Okay. So let us talk about index numbers. So index number is, one of them is BIS, or bispectral index. It's a commercial monitor which gives you a number between 99 to 0. It was because what happened in the 90s is that there was a renowned interest to have monitors to reduce the incidence of the awareness under anesthesia. That is why so many monitors were introduced, and to make life easy, they said, okay, we'll have EEGs processed, and some other bits are thrown in there, and then a algorithm was made by each company. And they did some studies and showed that if it is the basis between 40 and 60, probably it is within the clinical range. It's not exact science again. Okay, so there are at least 10 monitors that are available currently, which do the similar job like BIS. I have known about Entropy and SedLine or Massimo monitor. Their anesthesia range is between 20 to 50. There is Narcomed, etc. So what is the advantage of having an index number or a BIS-like numbers? It's a simple numerical value. So you can say, okay, the BIS is below 40, BIS is above 40 and below 60, we are in the anesthetic range. But what are the disadvantages? So you just imagine yourself looking at the heart rate, the number, and saying that, okay, this is the heart rate, but you have never looked at the rhythm, heart ECG rhythm. So that it's the same thing. So it's better to look at the waveform, EEG waveform, understand what is happening, and then look at the number. Okay, because the BIS numbers can be affected by the EMG, muscle movements, artifacts due to external sources such as cautery, electrical fields, physiological pathology, and like hypotension, etc., biological age. And it's not that as soon as you measure the EEG, it is right on time. So there is about a 30 seconds lag between the measurement of BIS and it is displaying on a monitor. And you can't say that, because people are different. People have got, and there are various types of anesthetic that you can do with different type of agents. So each of these will show different morphology of EEG, and we can't use only one index or one algorithm for all these. So this is the disadvantage. For example, if you use ketamine, nitrous oxide, and even ephedrine, it may show higher BIS even when the patient is anesthetized. And also dexmedetomidine. If you look at the waveform, you may think that, oh, this patient or the BIS, patient is completely anesthetized, but you can easily wake them up. So just a few words about awareness under anesthesia. So EEG indexes, as I was talking to you, became popular with a view to prevent awareness. But there's a difference between awareness and recall, because some patients may be aware, but will they recall what happened? That's much lower than just awareness. They have done a lot of experiments with what's called as isolated arm technique, because you isolate the arm with the blood pressure cuff and anesthetize the patient, and you would have instructed the patient beforehand as to how they have to respond if they hear you. And they would do that one even under anesthetic, but they would remember what they have done when they were asked to do certain movements under anesthetic. So there is no recall. Okay. So what is the incidence of awareness under anesthesia? So it may be between 0.005 to 0.1%, depending on the study that you look at. But in general, if you look at all the papers, they quote a figure of about 1 in 1,000, which is 0.01% to, 0.1% to 0.2%. But the incidence is known to be more in pediatric patients, obstetric patients, cardiac patients, and more in female patients when compared to male patients. Okay. In the UK, there is we got Royal College of Anaesthetists, and they do audits, which is National Audit Project, short for NAP. And there are various NAP studies, audits have been done, and the NAP 5 was done to address the question of the depth of anesthesia. And their findings are that they called it AGA, which is Accidental Awareness Under General Anesthesia. So there were 2.8 million records, patient records were looked at, and out of which there were 147 cases of awareness under general anesthesia. So the estimation was 1 in 19,000 or 0.005%. And if you use the TIVA, the incidence was slightly higher, 1 in 14,000. And the incidence, if you used the neuromuscular blockers, then the incidence was even higher, 1 in 8,200. And in patients who are undergoing cesarean sections under general anesthetic, it was 1 in 670. So, but most of the awareness that they have quoted in NAP 5 were for 5 minutes or less, but 50% of those suffered from psychological consequences. Okay. 1/3 of this is interesting because 1/3 of these cases happened during the maintenance phase. That meant 2/3 happened at induction and emergence. Because we may have patients who are obese, who may have had airway difficulty, etc., etc., and patients who came for emergencies. All these patients are vulnerable for awareness under anesthesia, especially at induction. Okay. So NAP said that processed EEG is recommended during anesthesia, especially if you are using TIVA and relaxants. But how about use of depth of anesthesia monitoring of some kind, even for inhalational anesthetic? I think I'll talk about Association of Anesthesiologists guidelines in a minute. Okay. So basically, there are various areas of brain which are depressed during anesthetic, and or even otherwise, what constitutes the area of interest with each of the modalities that are on the left side here. So the consciousness is mainly to do with the thalamocortical component. So that is where we get depression of thalamocortical pathways, and that's what we are measuring from consciousness point of view. However, other things have to be depressed as well, like autonomic nervous system, etc. So what happens if you had too deep anesthesia? Okay. And when you have too deep anesthesia, as I was showing you earlier on, you can get anesthesia-induced burst suppression. The EEG becomes almost flat, or you may have a little burst of waves there. Elderly patients are mostly vulnerable for this. But what can it do? It can cause, or it can increase the incidence of postoperative delirium. And there are some papers which also say that cognitive decline can happen, but there is not much proof for the POCD. However, lots and lots of papers have said that postoperative delirium can get worse, and also it can worsen morbidity and mortality. So giving too deep anesthesia to prevent anything may not be a good idea. So I have seen that because I do a lot of patients under TIVA anesthetic, and I have always used BIS or BIS mostly, and that has helped me to take the imagination out of doing anesthesia. So other thing is also that I'm probably using much less of the anesthetic agents, because when we don't use any of the EEG monitoring, we tend to overdose the patient with anesthesia agents. So this is what I was talking about. Association of Anesthetists brought out guidelines for monitoring during anesthesia. And this was the latest edition in 2021. And what they have recommended is that one should use processed EEG during anesthetic, especially if you're using TIVA along with the neuromuscular blockade. And monitoring should start before induction and continue at least until full recovery from the effects of neuromuscular block is confirmed. Also, there is a role for processed EEG when in patients who are getting or receiving inhalational general anesthesia. This is because if patients had awareness during induction and at emergence, according to NAP, more than during maintenance, you using end-tidal concentrations of inhalation agents is not going to prevent it. So I think Association of Anesthesiologists certainly recommends that we should use EEG monitoring for all type of anesthetics. This is my diagram here. I'll try and see if I can use this pencil. Yeah, so this is the line which is like this whole undulation is delta wave. So we're back to the waves now. So delta wave is probably 0.15 to 1 second, 1 wave per second. So this is 1 second here. But on top of the delta waves, you have got small waves here, and they are alpha waves. Okay, so the alpha waves are there on the peak of these waves. On the trough, we don't have much of these alpha waves, alpha spindles. So when the patient is anesthetized with propofol, for example, and propofol and Remi anesthesia, you get this delta waves and alpha spindles. Yeah, so this diagram here, or this picture, shows that the EEG is being measured here, but it's at a higher speed of probably about 6.25 milliseconds. So this is the y-axis, which is time, and on the x-axis is on the horizontal axis is the time, and in the vertical axis you have the waveform, which is the amplitude is measured measured there actually. Yeah, and if you look at this one, this is like a delta wave, which is in red. And if you look at this, is a slower waveform here. And this is one of these waves split shown here slightly in an elaborate manner, and you can count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So 12 waves are there within 1 second. So what is it? It is alpha waves. Yeah. So other day, when we were anesthetizing one patient, I just looked, we had given propofol for induction, and the BIS monitor showed that the patient had a lower BIS of about 14. So you can see this is the EEG waveform, but it is showing now the ECG. So you can see sometimes this type of pattern. And on the other side of that, I can point to you a couple of things here. There is something called as SQI, which meant that signal quality index, because it measures the quality of this, and say this SQI is about 100. That means it's a good quality waveform. And there is EMG, because if you put the stickers on the forehead, it can measure the movements of the frontalis muscle, which then is displayed as EMG here. So EMG under a good anesthetic is about 20 to 25, 26, etc. But if EMG is in its 40s, that means probably the muscle is active, and probably there is some interference from the muscle movements. So I'll just slightly change gear here and get into what is called as power spectrogram. So you anesthetize the patient, and you will have, say, alpha spindles over delta waves. But what we have to do is, we can't keep on seeing this one all the time, but we need a trend of what is going on with these waveforms. So what they've cleverly done is to have a mathematical model of this. And there are three things here. One is time on the x-axis, and then on the y-axis you have the amplitude, which is measured in microvolts. And also you have got the each wave which has got its own frequency. So it's a 3D construction, but when you look at it, it's in 2D here. Okay, so if the amplitude is higher, then the power on the right side is higher. Okay, I'll try and so this is the delta wave, and this is the alpha wave here. And when it is constructed in a 3D fashion, you get this kind of picture. It is almost like you can imagine yourself looking at all the waveforms in a row, hundreds and thousands of them, but they are making like mountains and valleys, and you are looking at these mountains from the top. And that's the picture you will see here as a spectrogram. So in here, I'll explain that again to you. So there is time on the x-axis here, and on the vertical axis, you have got frequency. This frequency is of each waves, like it may be an alpha wave or a delta wave, as I showed you earlier on. There are delta waves. On top of that one, you got alpha oscillations. And on the right side, you can see that depending on what type of waveform is predominant and high power, it's called as power. And that is displayed in a color diagram here, and it's measured in decibels. So if the power is high, then it is shown in red. If the power is low, then it is shown in blue. In this spectrogram here, you can see the gamma waves are at the top. Actually, gamma waves, as you remember from what I've been saying, very, very high in frequency. In awake patient, you get gamma waves. And when the patient starts to go to sleep, then you can get high beta and then low beta. And alpha this is the alpha wave here, which is in red on the top, and the bottom red is the delta wave. So you can also have some theta waves in between. So this is a, I'll just go to the next slide. So this is what I was monitoring the day when I was doing anesthetic for one of the thyroid patients. After induction, it is like this. This is the alpha pattern, alpha wave, and at the bottom there is delta wave, and that is like a train track. And this is typical for remifentanil and propofol anesthesia spectrogram. Our base is 48, and you can see the raw EEG waveform here. I think it's showing a wavy form. That's the delta wave. On top of that one, there are alpha spindles. The alpha spindles are there. These are alpha spindles, and this is 25 millimeters per second speed. So one seconds is one block actually here. So 8 to 12 waves in a second. So propofol and remifentanil are TCI, each anesthetic to you. Each of these anesthetics have their own fingerprint. So for propofol and remifentanil, you get alpha delta pattern. So sorry, I'll just try and rub this off. So if you look at this waveform again, I'll explain to you that you got a red line here, which is around, you can see that the frequency is about 10 to 8 to 12 or so. And then at the bottom here, there is another red block, which is a where frequency of what 3, 4 or so of 3, 4 hertz. So that is delta wave, and then there is alpha wave. So alpha delta pattern. So alpha delta pattern. So if you are anesthetizing a patient with the sevoflurane, you can still get alpha delta pattern, but later on the theta becomes stronger. So this is the alpha wave here, and at the bottom there is red, which is delta, and in between you get the theta waves. And you can see that, say for example, here in this diagram, the anesthesia was started with the maintained with 1.1% sevoflurane, and the sevoflurane goes up. So there is more and more depression of that. And once when the entire sevoflurane is 2.8%, the patient is probably deep, and you can get burst suppression. And burst suppression is like vertical lines that are shown in here. What about ketamine? Ketamine is, as I was explaining to earlier on, ketamine shows a different EEG pattern, and because of that, you can get higher base number. So it shows alternating delta and gamma oscillation. As you know, gamma means there is increased frequency, about 30, 35, 40, like that. So that is why it is more in blue here. And also there is a bit of delta here at the bottom. So this looks much different to the alpha delta pattern that you've seen for anesthesia with the propofol or even sevoflurane. What about dexmedetomidine? Dexmedetomidine is one of, as you know, it's one of the alpha-2 agonists that we use in ICU mostly. I have not had much chance of using it in anesthesia, but it is very good for using for procedural sedation. So it actually, if you look at the waveforms, it resembles stage 2 of slow wave sleep. So there are slow delta oscillations interspersed with the spindles. And EEG may give an impression that the patient is deeply anesthetized, but you can easily wake the patient up. So that's the pattern that you see when you have a patient with the dexmedetomidine sedation, and there is delta there, and there is a little bit of alpha as well, but mostly they are. If you look at this pattern, you may think that patients fully anesthetized, but they're not. They're only mildly sedated. Okay, so just as a reminder again, with the propofol, you get alpha and delta pattern like a train track. With sevoflurane, you can get a similar one, but in between you may have theta. And again, ketamine, it is more of gamma and a little bit of delta there, definitely different looking to propofol and sevoflurane, dexmedetomidine. Again, this is the type of pattern you get. So all I want to say is that every one of these anesthetics, you look at, you have to look at the spectrogram. Otherwise, just looking at BIS numbers or even the waveforms may or may not be giving you all the information. So what about increased age? With the increased age, the alpha power gets reduced, and burst suppression is more evident. If you look at this diagram in here, this is a person who is in the lower panel. I can say that the propofol general anesthesia, you can see the alpha and delta waveforms are there in patients who are up to the age of 65. But after that, this alpha becomes a bit less prominent. So another thing, concept that I want to introduce here, it's called a spectral edge frequency, because all the spectrogram that we have seen so far, it is measured with the power at the bottom there. So whatever power of the spectral edge, spectrogram is there, and if you there are two lines that you can draw there. One which has got spectral power 95% and then 50%. So the spectral edge frequency is a frequency below which 95% of the power is present in the spectrogram. And it is closely related to alpha wave spindles in 1 second. So about, say about the alpha spindles are about 10 to 12, our spectral edge is around 12 or 13. And it starts to go up as the patient wakes up. I'll just show that again on this spectrogram, which you have already seen with propofol anesthetic, which is alpha here and delta here. And can you see this white line? That is the spectral edge frequency, and that's around 12 or 13. So once when the patient starts to wake up, it starts to go up actually. And if the patient is becoming a bit more awake, the spectral edge will go up. So you can deepen the anesthetic to bring the spectral edge around the amplitude or even frequency that was there beforehand. So what about patients who are using chronic opioids? There are some studies which are a bit controversial. You would imagine that they need more anesthetic. Yes, common sense tells me that they need more anesthetic, but there are some papers which say that they may even need or require less drugs to maintain anesthesia. What about chronic pain? So that's a little bit of my interest. Chronic pain patients may exhibit changes in theta frequency band, which is not observed in opioid naive patients. So in conclusion, I want to say that there is a lot of advance in EEG technology that has prompted the use in anesthesia, especially to prevent awareness under anesthesia. So EEG definitely has a place in modern anesthesia, more so when you're using TIVA anesthetic and muscle relaxants. However, I recommend that EEG monitoring is used for every kind of anesthetic that you do, general anesthetic that is, that will take imagination out of anesthesia. Appropriate use of EEG may reduce the incidence of postoperative delirium, especially in elderly patients who will go back to the ward and they don't know what's happening to them. So if you can manage their anesthesia by using appropriate amount of drugs, not too deep anesthesia, that is. So understanding of waveforms and processed modalities such as spectrogram and spectral edge frequency is important, in addition to the indices such as BIS, for example. So I would say that one should not entirely rely on the BIS numbers without seeing the waveforms and also correlating with the patient's conditions such as hypertension, use of various types of anesthetics like nitrous oxide, ketamine, that can increase the BIS numbers. Okay. I have got a lot of articles. If you want me to share with you, I can share it with you. But I would urge you to look at these two websites, and they got fantastic amount of information and also videos. ISTAP.org or EEG for anesthesia, IARS.org. I'm happy to take any questions. Thank you very much. Thank you, Vaishali.
Yeah. I'm here only.
I'll try. Shall I stop sharing? Yeah. Okay.
Yeah. No, it's okay. Thank you, Dr. Vinod. Excellent presentation and detailed explanation about process EEG. I've been after you for so many months. Very good. So I will open this session for queries and questions. But before that, I have one question. Can you go on your slides, please?
My slide?
Yes, please. Or I can, yeah, yes. In slide number 25, 26.
Right. Let me just go back again, share the screen.
Yeah, please.
25, is it?
No, same, these two. Yeah.
Yeah. Sorry. Is it not displaying?
It'll come.
Okay, it's displaying something different. Let me just go back. 25, you said, isn't it?
This one, yeah.
Yeah, that one. Yeah. Yeah, okay,
So,
yeah.
in this one, the first slide, this D figure.
Yeah.
So,
So,
so can you tell it looks like spectral Doppler. So like how
so
do colors
basically,
correlate with waveforms?
Yeah. So basically, this is a spectrogram. Okay. So it's a 3D model. On the x-axis here is the time, 0, 5, 10, 15, 20, like that. And
Right.
on the y-axis, there should be a frequency. Okay. And
Yes.
then you got power. So so what happens? So if you imagine that there are waves, multiple number of waves from here to here going all the time, and they are stacked next to each other. And
Okay.
when the waveform, say for example, you're using propofol and REMI anesthesia, and you will get delta waves and alpha waves, alpha waves, and there are hundreds of them lined from left to right, because it's the time, isn't it? And then you can imagine some mountains and valleys, and you can look at that from the top. And then if you tilt that one, imagine you're taking a picture of that, and then you're looking at that picture. So that is what the spectrogram looks like. It is a 2D vision of a 3D model.
Okay.
It's a little bit of a difficult concept to get into our head first, but once when you get it, you get it right. That's what happened to me actually. So once when you do that one on the right side here, so you got time in minutes, and the frequency on the right side, there is power. So if you look at the bottom here, there is delta there, and then there is alpha. And you know this white line here, that is the spectral edge frequency of 95%. And this white line here is the spectral edge frequency 50%. So what it is the power is below that line, actually, that white line. 95% of the power is below that line. So that is one of the things that you can look at also. So the more we use these spectrograms, the more we understand them, and the more we can look at, like it's like doing ultrasound, or it's like a pattern recognition, you know. So pattern, yes. You want me to show the next diagram also?
Next one,
Yeah. Yeah.
this
So
one.
in here, if you see exactly the same thing, on the x-axis you have got the time in minutes, and on the y-axis you have got the frequency. And because the frequency, if you see, gamma is very high frequency, and then you get batted. Okay, beta, the low beta, sorry, high beta, and then low beta. When the patient is anesthetized, the beta frequencies start to come in, and then you get alpha, and then delta. So if you look at the waveforms, you will get, if you look at the raw EEG, it's a waveform like a big wave. So they are all delta waves. And on top of these delta waves, you will see it's like a sea waves, on top of which there are small spikes. So those spikes are, or they're called spindles, and those spindles are alpha waves. So when you construct this picture into a time fashion the way in a 3D model, it's a mathematical model actually, and you'll get a diagram like this, and that is the spectrogram. So typically here you see a red band on the top, and that's the alpha waves. They're all alpha waves. And at the bottom here, you will see another red band, which is the delta wave. So if you look at anesthesia, if you do anesthesia with the sevoflurane anesthesia or propofol remitiva, you'll get this pattern. But with the CO, you can also get theta waves in between, like bluish line.
Okay. So this means the patient is fully anesthetized. If you
Yes.
see,
Yeah. This patient is fully anesthetized.
and if you
And if you,
if yeah, if you
so,
get full this half of the screen is occupied by blue color, what does
no,
that
that's
mean?
this is because the patient is waking up at the end on this one.
No, half of the screen is occupied by blue color. That means patient is awake,
No, 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 no,
getting
no,
awake. No.
no, 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 no. That because the power is below that. The power is below the,
Okay.
yeah, 95% of the power is, see here, if you see, the 95% of the waveforms that you see are below this line.
Yes.
Yeah, it doesn't mean to say that the patient is awake because there is some blue thing there. No. Yeah, the predominant ones are alpha
Alpha
and
and
delta. Yeah.
okay. Okay. Thank you.
Uh,
Thank you.
Dr.
Does anyone
Vaishali,
have?
yeah. Dr. Kadu here. Yeah,
Yeah.
yeah. I have one question for Dr. Vinod.
Hmm.
Hi, Dr. Vinod.
Hi.
It's a great presentation. Many of the things has been new to us. We have been using this monitor in our hospital
Yeah.
regularly.
Hmm.
The few things which comes into my mind that
Hmm.
we have been using a conscious sedation also, what we call
Yeah.
the procedural sedation.
Yeah.
So it's not hard. So what will be the use of this BIS or a process EEG in giving a conscious sedation in the areas outside the OT, like MRI, endoscopy, and a bronchoscopy or something like that?
Yeah.
Do you use a process EEG in that conscious sedation also, and what will be your parameter or the index? Like in general anesthesia, we say it ranges from 0 to 100. So what should be the range for conscious procedural sedations?
Yeah. Nilesh, thank you very much for your question. It's a very relevant question. What I'm saying is that it depends on what drugs that you use for sedation. If you are using propofol, for example, on a TCI model, then you can use BIS monitor with the waveforms. But the base number may or may not mean much to you unless you know that the waveforms are good. Yeah. But do you use BIS with what sort of numbers you are looking at in your practice?
Uh, Basically, there have been a literatures which has been mentioning the use of this in procedural sedations, but we have not been using. At our center, for procedural sedation outside OT, we are using midazolam and fentanyl only. Though we are trying to use dexmed as well. With propofol, we are not using that. We consider like a short general anesthesia or TUR totally. So outside operation theater areas, peripheral areas, I just want to know about the use of this. How clinically implicable it will be, useful it will be to monitor the stages of anesthesia. Like we categorize that as mild, moderate, and severe. At the procedural sedation or conscious sedation, we grade stage it like as per the Ramsey sedation score or in a moderate scale of sedation. So can BIS give a valuation on that? That the BIS index, this will be a procedural sedation and can be documented in future if we are using more in the peripheral areas.
Yeah. Very good question. And I think you can use BIS and whatever values that you may feel comfortable with, you can enter them. But believing only in a number is not something that I will go for. Because it is easy for us. I know, I understand that, because you need a numerical value, isn't it, to say this is good or this is not good.
Correct. Okay. But certainly it has values if you start using it.
You got to be comfortable with it, and then more and more you use, you will get used to it. I have only used this for say propofol sedation. Other than that, I've not used it because I didn't find it much useful to do, because when I do the pain block list, etc., we give them alfentanil. I don't see a need for using based on those patients, So, but I've never used it with the midazolam or any other drugs myself. No.
Okay. Thank you, Dr. Vinod. Thanks for great presentation. Thank you so much.
Does anyone have any questions for Dr. Vinod?
There are a lot of things on the chat here, isn't it? I don't know. I've not seen the chat.
Yeah. So hello.
This is Dr. Anil Parak.
Yeah. Hi, Dr. Vinod. I think the number which I'm the at the Global Hospital Parel. So I think the number, as we say, is 40 to 60 is anesthesia when you are giving mild sedation like midazolam and the fentanyl. They are always above 60. So the number will be around 60 to 80 range. But if the patients are like totally conscious, it may range up to 90. As you give propofol for procedural sedation outside, then the number may be little less than the 60 or maybe like 60 to 70 range. So that's a procedural sedation. The other thing with comment this I want to make for stroke, where both the topics were very excellent, and particularly strokes now in India, in every 4 minutes, one patient dying with a stroke. So the number are so high in India. And regarding the general versus conscious sedation or the sedation or the MAC, it's very important that it is important to have the blood pressure maintenance, not the type of anesthesia which is important like sedation or this general anesthesia. But there are a lot of papers which says that the blood pressure maintenance is the single most important criteria for the stroke patients when they are coming for the mechanical thrombectomy. And particularly the centers which has the neuroanesthesiologist or the the anesthesiologists who are trained to treat strokes. These are the center where the incidences or recovery are both equal, particularly in sedation as well as in general anesthesia. So the importance of blood pressure monitoring is more important than anything what you give as a general anesthesia, sedation, or this. So many centers, they don't give general anesthesia. There are many centers who don't give general anesthesia. But as the Dr. Augustine has pointed out, it's a radiologist, intervention radiologist who demands, there may be new radiologist or somebody who are keen to do under general anesthesia. But yes, it takes longer time and all. At our center, we have a code white activated as soon as the patient goes into the reaches to emergency, and within like 15 minutes or 20 minutes, we get the MRI, not the CT, and perfusion images, and the code is activated, and within 25 to 45 minutes, our patient reaches to cath lab. So we have a nice setup at Global Hospital Parel. And there are many cases, as Dr. Augustine has pointed out, that the recovery is on table. And we had a lot of patients whom we have seen the recovery at our table, and it's very satisfying for the anesthesiologist as well as the intervention radiologist.
Okay, thank you. Thank you, Dr. Parak. Dr. Albin, I have one query. Can you give regional anesthesia to your patients for stroke thrombectomy if they are very sick and unstable?
No, if they
Regional means the scalp block and
no, I don't think there is a role for scalp block in this. If they are very sick, then we need to assess whether this procedure can do harm. Yeah. So it is not that thrombectomy is the end of for everybody you should do thrombectomy. Somebody is with NYHA class 4 or severe aortic stenosis or cardiomyopathy with NYHA class 4. You can do a bit. You can't give them GA and then cause hypotension, then inotropic support. All that is going to cause more morbidity. So that time you have to at least go for conscious sedation or just awake and try do the minimal as possible. It can also cause harm. So that doesn't mean that everybody should get GA, especially if they're coming a little bit late. So sometimes we just can't do. We just can't. If they're very sick, if they have already aspirated, if they are in their extremities, they've got COPD plus diabetes plus hypertension plus cardiomyopathy, all these are there, then the life expectancy and the quality of life of such patients is already so low that you may not benefit from what you're doing. Yeah. So you just
So one other comment I again want to make about Dr. Vinod, the lectures. He has mentioned that post-operative dementias and all less as when you are measuring the base monitoring. We had the liver transplant center at our hospital, and when particularly patient coming with ALF, what we started using base, and we had come across this that the requirement of inotrop has gone down. So many times when we don't measure the base, we give more deep anesthesia, and the inotropic requirements are more as compared to the when we are using the base. So that will help. The base is the other way. That it will be unnecessary deep level of anesthesia, and unnecessary we avoid hypotension, which is relevant to anesthesia. This is just a comment which we observe.
Thank you, Dr. Parekh. Parag. Yes, but I mentioned that the use of base and use of EEG, process EEG of any kind, will make us use less anesthetic, especially in elderly patients, because if you use more, then you may get post-operative delirium. Some patients, there are some studies to talk about other things as well, but post-operative delirium is definitely one big problem that can be reduced, and also the morbidity and mortality. Yes.
Yeah.
Does anyone have?
Yeah, I would like to say that both the presentations were very good, and we learned a few lessons or few new points from both the things. My query to Dr. Vinod, that you mentioned that the spectral edge frequency increases as the patient becomes light. Usually the BIS does not predict recovery, or it is unreliable at the time of lighter planes of anesthesia. So is SEF more reliable, or can it predict the recovery at the end of surgery or something during the sedation level or something as compared to BIS? Because BIS is just not reliable for recovery prediction.
Thank you very much, Hemangi. Yes, well, what I was saying was that we have got a different way of measuring the EEG. How the interest started in EEG was that because EEG is very difficult. It's not like ECG, isn't it? So there was a big barrier for people to understand EEG and also to use it in clinical anesthesia. So the companies did these algorithms, and these algorithms were like almost like it is done for some 100 scenarios, one algorithm. So this is just like a number that people can rely on, and that made the thinking of anesthetists a bit simple, and they jumped into measuring or monitoring BIS. So I would say going by BIS numbers alone is not a very good way of doing it. If you don't have anything, yes, that is something that you have to go by. But I think if you use spectrogram, it will give you a longer term, it's like a trend over a period of time. So 30, 60 minutes, 2 hours, etc. You can have a look at the trend rather than just seeing the BIS numbers on and off. And 95% of the power is below the spectral edge. So that's one of the other measures by which you can see the trend rather than just one BIS number at a point in time. I hope I have answered your question.
Yeah, Dr. Vinod, I think if I'm not wrong, the SQI should be 100 before we judge the BIS value. Am I correct on that?
SQI, no. Yes, SQI, yes. Yes,
Yeah.
that's what I was mentioning in one of the slides, because it's the quality, isn't it? So how is because it's, if we knew how to look at the quality 100%, but we are dependent on the machine to tell us that the quality is good. So if the SQI, which is a signal quality index, if it's 100%, then we can say that our EEG waveform is accurate or nearly accurate.
Tells about technical integrity of the system. Sometimes the leads are not properly placed in the scalp.
Correct. Absolutely.
So if you see that it's 100%, then only you judge the EEG, so the BIS value.
Correct. Also, another thing that you have to look at also, Nilesh, is to look at the EMG, because if the patient is becoming a bit more awake, for example, and those frontalis muscles may be stimulated. So EMG also have to be looked at. If the EMG is about 20, 25, 26, etc., then it is normal. But if you look at the EMG and if it shows 45, for example, that means there is interference from the muscle contraction, and the BIS value that is displayed may not be exactly the value that is supposed to be there. Another one is, sometimes patients getting hypotension, hypertension. If you use ephedrine, for example, you can get higher BIS value. If you're using ketamine, you can get higher BIS value. BIS is also higher with the nitrous oxide. So even though the BIS is high, that doesn't mean that the patient is awake. So BIS value, you have to make sure that you are looking at the BIS value in relation to the clinical picture, as well as, I mean, there are many ways of knowing the depth of anesthetic, isn't it? You can look at blood pressure, heart rate, whether the patient is sweating or not, etc., which we used to do all the time. But this is only an additional help that you have. I always feel like this. I always tell everybody, why don't you use BIS? Because we see sometimes people using TIVA without BIS. I said, why don't you use BIS? Because it takes the imagination out of it, imagination out of what you're doing. So I would strongly recommend any kind of EEG monitor, BIS or a Massimo, SedLine, whatever you can get your hands on. Use it so that you will get more and more experience, and then that you can use it very, very confidently. Now, in the past, I used to use higher doses of propofol and remifentanil. Now I use probably about, I may have chopped about 1/3 of the dose, or even 40% of the dose now of whatever drugs that I used to use. Yeah.
One more
You'll get more confident. You'll get more confident.
Yes.
That's it.
One more situation where I find it useful is the intraoperative neuromonitoring, where we don't want the patient to be light and not move. So to ensure that the patient is deep, and while doing so, we may inadvertently give too much of anesthesia. So monitoring this definitely helps in fine-tuning the things. So
Absolutely.
yeah.
This is exactly what I was saying, that it will take imagination out of anesthesia.
Thank you. Thank you, Dr. Vaishali.
Thanks for joining. Any other questions? No, I think. Okay. So I think we can finish now. Okay, so thank you, Dr. Vinod. Thank you, Albin, Dr. Albin. It was excellent presentation, Albin. Everything you covered, everything, and Dr. Vinod, a detailed explanation about processed EEG. But I think I'll have to still again go through it to get into my upper story.
No, we should thank all of you for on a Saturday night.
No, on Saturday, even you spared your Saturday.
Saturday night, you're all sitting and listening to these topics. So
It's
thank
a
you so much.
pleasure.
Thank you so much for listening.
Thank you. And thank you, SAMS, Dr. Avinash Bhosle. Thank you, Dr. Hemangi, Nilesh, Ganesh. Thank you very much for giving technical support. And all my colleagues from UK, Anwar, Hilal, Madan, Dr. Deepak Shetty, is it there? Dr. Stanley, Fida Khan is also there. Thanks a lot. And Gahan Bose, thank you very much. And my anesthesia colleagues from Navi, Mumbai, thank you very much for joining on Saturday evening. Thank you, Dr. Avinash. He is in theatre. He's
thank you. So I participate in the
can't hear.
Sir, I was busy. It was a marathon season. Like this is third season continuous.
Oh my God. Okay. And I would like to thank Dr. Anil Parak also for joining. He is our senior most neuroanesthetist in Mumbai Global Hospital. So I thank you everyone and have a good Saturday evening. And I wish you all Merry Christmas and Happy New Year.
Okay.
Thank you everyone. Good night.
Thank you. Thank you. Good night. Bye-bye. Thank you.
Thank you. Thank you.
Bye. Bye,
Thank you.
Vaishali.
Thank you very much.
Thank you, Vaishali.
Thanks.
Bye.
Bye. Bye.
Bye, everybody.
Bye. Thanks. Thank you. Thanks a lot.
Thank you, Dr. Vaishali. What great presentation. Thank you so much. Bye.